Uh, so I'll give you the countdown, sir, so you can start from there.
Yes.
Yes. It's 5, 4, 3, 2, 1, go.
Good evening, everyone. I welcome you all to the virtual stroke grand rounds from Institute of Neurosciences, Kolkata. Today, we have two very interesting cases, and we have also renowned panelists with us. We'll be discussing the case. The first case will be presented by Dr. Shubhadeep Banerjee, and the other case will be presented by Dr. Ananya Sengupta. So, Shubhadeep, please start your presentation.
Yeah, good evening, everybody. So today I am going to present a case of stroke management, which we experienced recently in the first couple of weeks. So this is a story of a gentleman, 56-year-old gentleman, who is hypertensive on regular treatment, and he was recently diagnosed with type 2 DL, but didn't start treatment yet. He had a history of left hemispheric TIA around 2 months back, but at that time it was not evaluated. He didn't visit any conventional hospital. He was taking treatment from some alternative medicine. Now this time he had sudden onset aphasia and right faciobaccal weakness on 25th of June this year. And he visited a doctor who advised an MR at that time, which was done on 28th, 3 days later. At that time, they did an MRI brain stroke protocol. It was done outside. We do not have a very good quality image. But what we could see at that time is that, if you can appreciate from the screen, there is a acute infarct in the left parietal region, and on the MR top angio, there was a critical stenosis in the left ICA. I think it is appreciable from the picture. But the distal flow was still maintained at that time. So this was the background when we received the patient. In fact, it was on 28th June, he was planning to visit our hospital for further treatment. And en route, he had developed right hemiplegia and global aphasia in the evening itself. This MRI was done in the afternoon, 3 p.m. He was traveling to the hospital, and that en route, he had developed this right hemiplegia and global aphasia. He reached hospital within 1 hour of worsening, and at the time of examination in the emergency, his NIHSS was pretty high. He was completely plegic on the right side, had a gaze preference, facial droop, was aphasic. So his NIHS was 20 at that time. The onset of this new deficit was within 1 hour. So at this juncture, as because we already had a basic MR top angio, we knew that possibly that critical stenosis had gone into full occlusion, and that has possibly caused a large hemispheric stroke. So we just took him to the MR console and did a quick MR screening, DWI screening. And at that time, as we had expected, he was developing a DWI restriction in a large part of the left hemisphere, both including the purpurator territory and also on the cortical branches of the means left hemisphere, involving the frontal, temporal, and the parietal region. And here, this part, which is more bright, is the relatively subacute infarct that he had experienced 2 days back. So this at this time, we have a developing infarct, and a repeat of showed there was no flow in the left ICA. So at this juncture, the question toward us was that what should we do next? Should we intervene? And if we plan to intervene, then what should be the ideal modality?
Shubhadeep,
So,
I think at this point, let us ask the opinion from other people. The question is whether we should go for intravenous TPA in this patient because he came to hospital within 1 hour of onset of his second stroke. And then based on this MR angio, what looks like he has got left IC occluded. So whether he is also a candidate for an intervention. So Gautam, you have a comment?
All, the history is that 2 days ago he had the same event, right?
Yes.
the first event was 2 days ago, on 25th of June.
Yeah.
He had developed a right fasciabuccal weakness with some with some aphasia.
Right. So the first thing is that if you look at the first MRI, along with the fact that he had also the parietal thing, you can see that there is a watershed infarct going on, right? It's right across the junction that you can see there's a watershed infarct.
Yeah.
So you know this person has a proximal critical stenosis somewhere.
Yes.
Right.
And the pathophysiology of the stroke is mostly related to that it's a flow dependent stroke. It's not like a clot which came out from different places and do this. So number one, the fact is that if you think of the how can we open up the vessel, that's the main question. And the fact that he had a stroke 2 days ago and you have a MR documented stroke, I think the risk of TPA is high because there is a risk of hemorrhagic transformation in that area of this infarct. Generally, the recommendation is that in the last 90 days, if the person has a stroke, there's a relative contraindication. But if it's a week, you know that the blood-brain barrier hasn't developed, and then you throw this clot, this lytics into the infarcted tissue, there is a risk of hemorrhagic transformation.
Right.
And the second thing is that you remember also this is a stroke related to flow-dependent strokes. So it's not like a clot-dependent stroke. So I think the risk of or the benefit from using lytics in this situation does not outweigh the risk of the complications from it. So that's number one. Number two, you know that whatever the critical stenosis was, has been there for chronic, right? He's a smoker and that has been there for some time. But for some reason, his collaterals now has failed, which tells you that whatever you do, you have to open up the vessel. So I think that's what I would go for. And I would discuss with the family that although we will open up the vessel, which sometimes may be difficult because you have to not only open, but you have to stent these people. And then you have to put them on dual antiplatelets or whatever. There is a risk of a complication from opening up the vessel because there is an infarcted tissue. So you disclose that, but even though you'll have a hemorrhagic complication in that infarcted tissue, the benefit of saving that entire left hemisphere outweighs the risk of that hemorrhagic transformation. So that's my 2 cents.
Okay. So I think
That's what
was going on in our mind, and we had a discussion, and I agree with you that the risk of IVTP was way higher than the benefit. So we did not go for IVTP. Now, regarding the intervention, my intervention specialist is also here, Dr. Shukolan. So he can also comment here. So our discussion was that the earlier MRI, which he had the same day, showed there is a critical stenosis. So as we discussed, it is a flow dependent thing, and probably that is occluded at this point of time. So if opening that stenotic part of the ICA acutely, and obviously it is going to need a stent. So putting a stent in with a territory which is already infarcted a couple of days back, and another new infarct with risk of hemorrhagic transformations and hyperperfusion syndrome. So these two are probably on the higher side. So we discussed that with the family as well.
Right.
And we told them, look, we can do that. It is doable, but the risk is high.
Yeah.
And procedural risk with further stroke is possible. So considering everything, they did not agree for the intervention.
Okay.
So at that point of time, we managed him
Medical.
medically.
Yes, medical.
Right.
So Shubhadeep, you can proceed with
So
the.
একটা জিনিস Shantu. So let's think about the outcome and overall global picture, right?
Right.
So এইরকম situation, either
Hmm.
you have a white brain or a black brain, right? So either I mean, as far as the disability is concerned, the patient will have a disability irrespective of তুমি যদি কিছু না করো, that whole thing is infarcted and the patient will have a disability.
Right.
If you do something, there is a risk of hemorrhagic transformation, but there is also a risk that it may not happen,
It
right?
may.
But if you don't do anything, we are absolutely sure, 100% that this patient would, have a massive MCA syndrome and then eventually, whatever happens. So I think the thought process is absolutely correct, but that's what I discussed. That if you want people to survive and be aphasic and not moving one side, versus giving the person a chance of, okay, if we do something, maybe we will be able to do it. If we don't do something, maybe we'll be able to open it up and reduce the amount of infarct. So that's actually the dilemma, and I fully agree that I think opening this vessel, there is a risk. But what is, the risk is always there in stroke care, right? So we all have to take risks. It's a matter of, go ahead.
Yeah, Shukalan, you have a comment?
Yeah, absolutely. Like whatever has been discussed is absolutely to the point. There is obviously a risk, and the probability of getting some success is there, definitely. So yeah, but we also, I think, when I saw this image, the DWI, I also told Shubhadeep, the large area is infarcted and very high NIH, and so we have to explain a risk of hemorrhagic transformation.
Absolutely.
And if they agree, then we can do that, because
absolutely.
we have to put the patient on double antiplatelet with a stent, and that was So that was actually.
So this is a kind of lose-lose situation, So
Yeah.
whatever you do, there's a loss, but the question is that if you do something, is the loss a little less than what is thing? Now you have the DWI. Can I see the flare, or is the flare there?
No, actually, we at that point we did only that the onset was known. It was within 1 hour, and we did only the DWI screening at that time.
Right.
So,
but in my situation, if this is the situation, I would do a flare. The reason is the flare tells you, at least, we know this the onset is 1 hour, but you also know this is a guy with a critical stenosis. So he has been having some hypoperfusion and all that stuff altogether for some time, but he has been able to compensate that through his collaterals. But eventually that failed on that day as he was driving in. So if the flare changes are there, I wouldn't do anything. So if the DWI with the flare changes are there, I agree with, and then I'm not even offering this to the people.
Yes, of course.
Because then you know that you didn't do anything good, and you're actually harming the patient.
Absolutely. And just one point here, I want to know that if we also add a gradient, because the gradient doesn't take much time, that might also tell us whether if the patient has any load of microbleed, or whether any bleed is already there in the already infarcted, the diffusion, which is bit older one. So that also will help us to prognosticate something. Yes.
But Shukalan, I think I agree, but also the fact that even if you bleed into that area, right? If I take the worst case scenario, we open this is the exact same situation. The diffusion is positive. The flare, it shows only positive changes in the area of the previous infarct, and you have the rest of the MCA clean, right? Now we offer the patient, okay, this is the option. it may backfire and it may cause the whole area to bleed, and we may have to, that may cause loss of life, versus this person completely in a nursing home dependent for the rest of their life. If the family agrees that we'll do it, and if we do it, and if there is a hemorrhagic transformation in that area, it's still survivable. If we can prevent that extra infarct which is going on, and I agree with you that I think there will be flare changes there, but still I'll take that risk because I'm trying to save that 2/3 territory instead of the last parietal lobe.
Well, let me discuss this in a different way. Let us go back to the evidence. I mean, how correct we are by doing an acute stenting in a patient with an acute stroke. Now, if you look at the intervention studies, ESCAPE or similar kind of studies, some patients, they required an acute stenting in the neck, the carotid of the neck. If they have a tandem occlusions, they did a stent and then they reached the MCA and removed the clot by solitaire or something. Now, right. This is a little bit different situation than this, because this patient had one infarct already in 2 days back. So in this situation, if you look at the evidence, then evidence is probably, non-existent in this kind of situations. So what we are talking about or discussing is basically based on our understanding of the disease and the risk-benefit analysis. So I think if we do it, we have some reasons. If we do not do it, we have some reasons.
Yeah. No, so, I think that no one can fault you for not doing it.
And secondly, the practice of this kind of interventional and aggressive treatment is very much dependent on the geography where you are doing it.
Yes, and absolutely.
Stenting in our situation cost you some money. So
yeah, absolutely.
The expectation goes up. These are the things are important.
I can tell you that out of 7 of my intervention people who are doing this, 4 or 5 times a day on every single day, I can tell you there will be 3 who will be doing it. The rest 4 wouldn't even touch it. Okay. So it all depends on the confidence of your person who is doing it. Number 2, all depends on your discussion with the family. All depends on, who's the pair. All of these have to be taken into account.
That's right.
But so see, one part is the theory, right? Like that you do this. The other part is what's the practical part. And if you tell someone that, hey, I'm doing something which it can cause the person to die, or even if they do something may not work, and most likely would not work, but you will have to pay 2 lakh rupees for that.
Out of pocket.
Yeah, out of pocket. That doesn't even exist. You can't even bring that to the equation. If I'm the family member, I'm sitting in a place which is a comprehensive center. We're getting 10 interventions coming in, of which we are doing 5 every day. That's a different scenario than someone who is paying out of their pocket. Here we have 98-year-old who comes in with a stroke and they say do everything, right? Because they don't have to get out of your pocket. So my situation is completely different than your situation.
Correct.
But also the fact that what you brought up is important, that we don't have any data, but there's a lot of data we don't have any data in a lot of things in medicine. And you try to put the things in place. Either you have a black brain, which is totally infarcted, or you have a white brain, which is you have a bled into the brain. So that's how I distinguish. But this patient in my case will get a hemicraniectomy. We'll get all the treatments which is needed to be done on day number 2. We are not even waiting for day number 3 for the patient to be drowsy and stuff, because we know it will be a malignant. So it's a completely total different scenario than what we are talking about.
So let us look at the next events.
Yeah. So we also decided against doing any intervention at this point, and decided to go for medical management only. So as we have already discussed, these were the possibilities that we considered. Now, the next day morning, this was the CT scan that we had. We repeated the CT and this was the CT. So here we can see that infarct was already developing in the affected part, but the perforated territory was probably not affected that much. And the patient was doing well compared to the load of the infarct. He was arousable and was localizing to pain at that time. And also there was some movement appreciable in the right lower limb. So we continued only with the anti-edema measures, and on the next day, we decided to do a repeat formal DSA in this patient to have a look at the vasculature, status of the vasculature. Now, during DSA, Dr. Prakash had done that. So the right IC injection, it was the right-sided IC was feeling well. Both the ACs were feeling from that right ICA, and there was some flow in the left MCA to the cross flow to the ACOM. When we saw the injection in the left ICA, it was totally occluded in the cervical, beyond the cervical part, and there was no flow in the MCA from that side. The ECA were feeling, and there were some collaterals that were giving the left hemisphere some blood supply. When coming to the posterior circulation, the left vertebral was possibly the dominant one, but and the right vertebral was also well visualized, but there was no possibly not much feeling from the posterior circulation to the anterior circulation, as we can appreciate from this picture. So this guy is possibly having a left right-sided left MCF with some feeling from the cross feeling from the right side, and but the left ICA injection did show that there was a complete occlusion from the beyond the cervical part. So we continued with dual antiplatelet later on. After repeating the CT scan, there was no hemorrhagic conversion, and with high dose statin, and now with conservative management, he is doing well. This is his CT scan, today's CT scan. This has been done today. It is the day. It is just the day 12 of stroke, and we see that there must have been some spontaneous decolonization of the stenosis, whatever have been, what we can appreciate from this new CT scan, because some part of the cortex are also spared. So now he is little stable. He is taking orally, and he has started movement of his right lower limb, and he has been mobilized out of bed. So he is doing reasonably well compared to the initial scan that we had at end of second week. So that's the case.
So this is, I think this is the uncertainty of stroke medicine, where something happens which we do not even anticipate, either the good way or the bad way. And this patient, we were actually preparing for hemicraniectomy next day morning. And surprisingly, a big part of his cortex got spared. And even if you look at his basal ganglia, some part is spared. I think that is the reason probably he got saved from decompression.
So I think there are two things to, first of all, when you say medical management, what did you do? Like, what is medical management?
We gave only, initially we had started only on single antiplatelet and 80 milligram atorvastatin with anti-edema measures in the form of mannitol initially. Later on, after 3 days, we repeated a CT scan, and as there was no significant hemorrhagic conversion, we started the dual antiplatelet on second, third day. And
here, actually, I just add one point. Here, patients who who might need decompression in a day or two, we usually do not put them on dual because the surgeons don't like clopidogrel.
No, except for no antiplatelet. What about like the position, like the head end down because you know this is a flow dependent. Sometimes
Yeah, we
these things are
maintained this. We maintained the systolic blood pressure in the tune of 155 to 160, and also we kept him on IV fluids. We maintained the hydration status well because
Right.
we knew that it was a flow dependent stroke. So always we thought of that if we can means maintain the circulation map, then it is the means perfusion pressure.
Right. So the second point is right, that that the reason this the peripheral and some of the cortical branches got spared is because it's something chronic and patient has a collateral, and the external carotid is kind of filling in all the meningeal branches and stuff. So that's the benefit of a chronic, if there's anything like that, benefit of a chronic occlusion, that although the system failed, but there was a chance for the brain to get some of the collaterals going and fill up some of the peripheral arteries, a peripheral part of the tissue, and so the infarct was low. And I think because the ACA was cross-filling it, you can see, as you mentioned, the proximal
Yes.
branches, mostly the lenticulostriate
Yes.
branches were
got
saved. And so it was a kind of a distal M1 or M2, which was the problem. And what happened was that because the collaterals were filling in from the periphery, so the middle part got involved. And so, I mean, it's a win-win for the patient, actually. So without spending 2 lakh rupees to do something and die, I think this was the better outcome.
Shubhadev, is there anything else to show?
No.
Okay, so I think
Okay, I will close
we
my
can conclude from this case that this is one of those difficult cases where we had to give a lot of judgment for not doing acute treatment despite having the patient within 1 hour of the onset. And fortunately, the outcome was not that bad what we anticipated at the beginning. So this is another, this is one of those examples of the dynamicity of the disease.
I think this is an example where doing nothing is the best option.
Yeah.
But the problem is when you're in the bedside and this is happening and the family is looking towards you, you always feel like obligated to do something. Because in our era of where we practice, doing something is better than not doing something, because you have to speak up to 12 other people when things go wrong and say, why didn't you do it?
Right.
So if you had a diffusion positive and the flare was negative, I can tell you that 10 people sitting across me, they will all say that we should have gone for it. Now, if this thing is outcome which we knew already, then it's a different thing. But even if you have a disability, people will say, well, maybe we should have gone for it and the disability would have been not there. So it's a very, very different practice situation here, because everything is objective based. Like, okay, you had an MRI, the MRI didn't show any flare changes. Why didn't you go for it?
Right.
So you have to explain to that hey, so that's the reason you explain all these things and you do it. But definitely TPA is not an option, and this is but it's a good outcome. And this is the thing which tells you always that you don't know always what you do on the first day is what happens with the patient. We think we did a lot, but maybe not.
Yeah, so that is it. Thank you very much. And I think we should move to the next case. My colleague, Dr. Ananya Sengupta, will be presenting the case. Ananya, go ahead.
Yes, sir.
By the way, do you have perfusion scans, Jonathan?
Yeah, we do have.
You have perfusion scans?
Yeah,
No, we didn't do perfusion on this patient.
in this case,
But
we
you-
didn't.
But you do have it.
Yes.
You do have perfusion scans there, right?
Yeah, we do.
Okay.
We can do it. We have CT perfusion, we have MR perfusion. We can do either.
Is the screen visible, sir?
Yes, it is.
Yes. Yeah.
My case is
Make
it's
it
quite
full
simple. Hello?
Make it full screen,
It is full screen on my side, sir.
but here it's still small. Try once again.
Is it full screen?
Not yet.
Not yet.
It's showing the
You
timer.
stop sharing and then again start. Then.
Yeah, try that once again.
Yeah, that's better.
Yeah, it's
So this patient, which I shall be presenting today, is again another one who had left us with a dilemma whether we should be going for an action or whether we should hold back. So this patient was a 58-year-old gentleman, hypertensive, who was last seen well at 3:15 a.m. on the 6th of July this month. And when he had gone up to go to the washroom, and while coming back, he had developed a sudden onset slurring of speech with the right side of hemiparesis. This gentleman presented to our emergency at 6:50 a.m. on the 6th. And at the time of presentation, his NIHSS was 13 with a right-sided hemiparesis, and he was also having an aphasia and sensory deficit. At the time of presentation, his blood pressure was 130/70 and his blood glucose level was 90. So when the patient presented to us, we went for the CT scan of a plain CT scan of the brain, which showed an aspect of 0, and there was no hypertension that we could see. We proceeded with a CT angio.
You mean aspect of
10.
Sorry, aspect of 10.
Yeah.
And we next went with the CT angio. So in the CT angio, we can see that in the left M1, we were suspecting a large occlusion present. So this patient, since he had presented to us within the time window of 4.5 hours, we went for with the consent of the family members, we proceeded for thrombolysis with IV alteplase at 0.9 milligram per kg. We started at 7:30 a.m. Post thrombolysis at 8:30, the patient's NIHSS was still 12. There was been only minor improvement in the right-sided hemiparesis. So next, we shifted the patient to the cath lab for a possible mechanical thrombectomy. Now, when we took the patient to the cath lab, this is on the DSA. This is the picture which we saw. You can see that, and the left M2, we can see the presence of a narrowing, but the distal flow is very well established. This is at the time of the DSA, which was around 9:30 a.m., which is around 6 hours post the onset of symptoms of the patient. And as we can see from the rest of the DSA, that the flow was very well established. And when we were examining the patient in the cath lab at that time, his deficit had also improved. He was having an NIHSS of 5. He was having a power of 3/5 in his right-sided upper limb, only a drift in the right lower limb, and his aphasia had improved to a great extent. So this point of time, 6 hours post the onset of symptoms, we were really left with a dilemma that what we should be doing next. So at that time, his blood pressure at the cath lab, it was 170/90 millimeters of mercury, and the NIHSS, as I said, was 5. So the question was, what should we do with this patient? Should we proceed with the mechanical thrombectomy? Should we go in for a stent, or should we proceed on? Will we stop here and proceed only with conservative management?
I think let us discuss the case at this point of time, and we'll tell what we did. But Gautam, what you would have done in this situation?
So first of all, when you think Sukolana is there, so maybe I can ask him also. So when you did the DSA, there was no clots, right? It was no LVO per se. It was just that area was stenosed.
Correct.
Yes, sir.
Right?
Yes, sir.
Yes, yes,
Okay.
yes.
Yeah, okay.
What we saw in DSA is that there was it was very difficult to tell whether this was a clot or an atherosclerotic plaque, but that was around, maybe around 30% of the luminal compromise was there, and rest
Okay.
of the lumen was quite well preserved. And there was no delay in the distal flow of the blood, and the wash off was quite normal as compared to the other vessels. So then there was a dilemma whether we should go ahead and try to suck that thrombus out, or try to take the thrombus with a clot, or just leave it like that.
Yeah, technically the forward flow has been reestablished. So,
Right.
I mean, the indication of mechanical thrombectomy doesn't hold good here.
That's correct. I would agree.
Yeah.
Now, one other thing in the evaluation. So this patient, when you were doing it, is on the table, right? So he's laying down and you are doing the procedure. So the evaluation is mostly when the flow is maximum, right? It's not like we are sitting up the person and seeing if that thing is compromised or anything, right?
Right.
Okay. Yeah, I think if the forward flow is there, I think if the distal branches have been, as you can see, looks good. I think sucking out the clot, and I'm not sure, and if the clot is only 30% of the thing filling up, yeah, I think the mechanical thrombectomy, you have to, that would be an issue.
And I should not say it's a mechanical thrombectomy, because
But yeah,
I'm
sure.
not sure whether there is a thrombus.
Right. So it's if anything, you have to aspirate this, and first of all, I agree with you. I don't think it's whether there is a thrombus or anything there.
Right. So our discussion was at that point that Shukalan feels that once he reaches there, he doesn't know whether he is dealing with a plaque with the stenosis in situ or a thrombus. So he might have to put a stent in and
Right.
come out. If it is turns out to be a stenosis, right?
I'll just interfere here. Like what, because this is the superior branch, and that's the main, that's the dominant branch of on the left side. But if you see that there is delay in the circulation,
Right.
then probably it makes sense to open it up. And the other thing is
Right.
that it didn't look like a thrombus. It was not inside the lumen. It was probably an eccentric one, which is attached to one of the wall. So it was not looking like, it was not looking like a clot. So probably there was a clot which formed on the surface of the thrombus, the surface of the plaque, which got dissolved.
Distally,
with
the so yeah,
IVTPA.
agreed.
So we thought probably we can do it later also.
Right.
Right. So I'll tell you what we would have done. I would have done that exactly what you did. We would have just come out. We would have watched the patient, and with the thing that this patient is monitored in the ICU with neurochecks and everything. And if it worsens, that's the time we may have to do something. But until and unless it worsens, I think we are happy where we are.
Ananya? Shuhas?
So at this point of time, since the patient was also doing well, and we decided that there was also possibility of a plaque rather than a thrombus, so we went for a conservative management. However, though we planned that we would be not going for any further intervention, we would be repeating the CT later on in the evening, and we would be starting with first a single antiplatelet, and then we would be switching to a dual. However, around 1.5 hours later, when the patient was in the ICU, again, the NIHSS had dropped to 12, and there was re-emergence of the right-sided motor deficit along with the aphasia. At that point of time in the ICU, his blood pressure was found to be around 140 by 80 millimeters of mercury. So we immediately shifted the patient to the CT. This is the CT which is done at the time of when the patient detubated, that is 1.5 hours after the DSA. And here we can see that there is the infarct is developing in the left MCA territory. And we were thinking that there is a possibility that a larger area of hypertensity was visible. So at this point of time, the question again arose of what we should be doing. Should we proceed with again take the patient to the cath lab and proceed? But we need to remember that at this point of time, the patient was around 9 to 9.5 hours from the onset of symptoms. The patient had already been thrombolyzed with a full dose of TPA, and we were now left with the dilemma that if we went for an intervention now, would we be increasing the risk of the patient further, the bleeding risk of the patient further, as compared to the benefits that we would be giving him? So,
And another point was, I mean, given the DSA picture, if you remember, where it was not even a significant stenosis. It was
Right. It's only 30%.
30-40%.
Yeah.
So that should not give a hemodynamic stroke or TIA kind of thing. So we thought whether it got reoccluded.
Right.
That was on one discussion. So if it reoccludes, then going in and then intervention, possible stent, dual antiplatelet, on a patient got TPA. So a lot of risk was involved. So, and again, another point was, whether Anand has mentioned or not, the patient again started improving.
yeah, we'll come.
Yeah, okay, show us.
So by the time we shifted the patient out of the CT, the FAC had improved within 30 minutes. By the same evening, by around 6 p.m., the patient NIHSS had again improved to 5. The right-sided deficit had again improved. He was having a power of 3/5 in his right upper limb, only a drift in his right lower limb. So at this point of time, we decided that we would be repeating a CT at 24 hours post thrombolysis. We would be maintaining the blood pressure of the patient towards a higher side, around 150 to 160 of systolic, and we plan to start Ecosprin the next morning after we had done the CT scan, which was 24 hours post thrombolysis. The time we did the CT scan next morning, this was at this time the patient's NIHSS was 5, which was around 6:30 a.m. in the morning of the 7th. This is the CT scan which was done. And as we can see, there has been no further extension of the infarct as from what we had seen in the previous CT scan when the patient had deteriorated. However, this, as I said, this assessment was around 6:30 a.m., which is around 24 hours post thrombolysis. By 9:30 a.m., again the NIHSS had dropped to 30 with re-emergence of this motor weakness and hemiparesis. Now, this time we decided that we would be shifting the patient to the MRI to see if an infarct has developed or not. And this is the MRI, DWI, and it is screening along with the MRA, which we did when the patient's NIHSS had again dropped to 30. As we can see, we have the presence of watershed infarcts in the left MCA territory, this and here, which had become well established by now. However, when we are looking at the MR angio, you can see even though we do see the occlusion of the left sided from M2, it is not that it is completely occluded. We can appreciate some amount of flow in the distal branches of the MCA. So, so this was a situation which we were presenting, that is the next morning post thrombolysis, when, as we had seen from the DSA, that there was a non-significant stenosis at the left M2 and the patient had developed an infarct right now. So again, the question arose that what could we do for the patient at this point of time? I think considering considering the time which had elapsed, we decided that it was really, there was no point in going for an intervention at this point of time. The patient already had developed an established infarct with the right-sided hemiparesis and motor aphasia. So since there was no bleeding, we started with antiplatelets, and this for the patient, we loaded him with Ecosprin with a 325 milligrams dose, and we followed it up to 75 milligram, and we started the clopidogrel on the 75 milligram on the same day itself, that is 24 hours post thrombolysis. The patient still continues to be under our care. His rest of the investigations are going on. He has not shown any further deterioration. He continues to remain stable with the right-sided hemiparesis. There's been some improvement of the power in the distal muscles of the right hand, but the aphasia has not shown any improvement as yet. It's predominantly a motor aphasia. The comprehension is more or less intact, and we are continuing with rehab and other conservative management.
Right. So I think this case brings about few interesting questions. The first of all, when the patient worsened the next day, and in the MR angio, we can still see some flow in the M2s, then is it a reocclusion at that stage, at that level, or it is just collaterals which has failed? Because the infarcts were to see in the DWI, mostly in the watershed areas. So watershed areas and some cortical distal infarcts, which could be, I do not know, maybe the fragmented clot post TPA, which gone into the distal circulations, and some of them are responsible for that. So this is a very interesting area where the patient worsened, fluctuated a couple of times in the next 24 hours and eventually had an infarct, despite having a 30 to 40% stenosis. So, Gautam.
So I think, yes, I agree with the whole thing. Now, so let's go back into the pathophysiology. So this is he went in and he saw 30% or 40%, occlusion, but I agree that, maybe the occlusion was higher because there was an in situ thrombus, which we displaced or which we broke up with the TPA, right? And then there was a distally, some of the fragments went, and there was already a compromise of that whole system. So the collaterals could not hold up anymore for anything subtle changes. And if you see the first time this happened, the blood pressure dropped to 140, right? The first event. So, was it a flow dependent thing? We don't know, but at least when we increased it, we kind of overcame that. Now, the question is, you did a CT which showed some early changes which were already happening before. Now, I'm just putting myself in your situation and trying to see what we would have done here. So in this time, I think we would have done the thing. We would have put the head end down. We would have just blasted the patient with fluids and tried to keep his, systolic blood pressure high with bolus of NS and everything. We may have thrown in the MRI there just to see what is happening, or we may have done a perfusion scan there. But I can tell you, if you did a perfusion scan, most likely I would be fooled, because the perfusion, would be abnormal because he was having symptoms. So then it would make me more eager to do something on the patient, which his system was already trying to compromise and do the best for him. So I think that sounds okay. Now, you brought up a point that, TPA and doing anything after that. Now, if we know by what the TPA half-life is 30 minutes, right? So after 30 minutes, PPA is out of the system. If you have renal failure, the TPA half-life is higher, but the FDP products are much in the system for a longer time, and that's the reason we don't have any data whether antiplatelets or anticoagulants should be started. But as you know, there is a trial now with TPA and antiplatelets at the same time here, and we are participating in the trial. And there's also a trial, the Japanese trial also showed that if you do TPA during the intervention, the outcomes are better, right? So, so I think if we have to rethink now, so I think everything what you did was what I would have done here. There's no question about it. Now, why did he worsen the next day? Again, is it a perfusion thing? Was he sitting up, during this thing, when it happened? Because I think the system was trying to compensate for the whole thing. I mean, the collaterals were trying to compensate and everything was there. And I agree with, now looking back, I agree with Dr. Purokastho that most likely wasn't a clot. That was a something of a plaque, which was just symptomatic. And there was a thrombus on the plaque, which caused him the stroke to start with.
Right. Shukrlan, any comments?
Yeah, one part of the story probably she missed, that both of we talked that, when the patient deteriorated, you call me immediately that should I send back the patient to cath lab again? Unfortunately, I was in another case of aneurysm coiling, and And then once I finished, probably in an hour or so, I called you. And you told that, yeah, because it's already 7 hours, so probably we should not do that. So that's
And
another
patient
problem.
improved by
We
that
have only
time.
one cath lab. And the other thing here, what I want to mention, that because you have given TPA in this, so probably the stent or anything at that point of time will not be justified, at least for 24 hours, because of the issue of the double antiplatelet. But after 1 hour, when the patient deteriorated, probably if our lab was available, we could have gone in and tried to, because that was repeating. So at that point of time, we could have tried some suction or whatever, at least to see. When you go in, you will have a more understanding that whether you are dealing with a clot or a plaque.
Another thrombus.
And yeah, and this surface of the plaque probably was ruptured or some
Right.
irregularity was there, which was attracting thrombus.
Right.
But again, if you do not open it up with a stent, they tend to close again and again.
Yes. Yes.
That is another issue here.
Yeah. But
And,
also the fact that you had so much distal flow and you had so much good, I mean, it would be difficult that,
Justify.
and I agree that to justify that that what are we treating actually, right? If it's 30-40%, and even if it's symptomatic,
yes.
it's something I don't think will, eventually, as we saw, that the collaterals came back again. Now, one other thing, Jayanto, in this discussion is that when we load up patients, we load with, the 300 of Plavix and 325 of aspirin, because the mechanism in this is mostly, I think it's mostly the collaterals have failed and the perfusion is building up. So I generally load them up. If it's after 24 hours, I don't have any concerns of anything. I just load them up with 300 of Plavix and 325 aspirin if they can swallow. And if they cannot swallow, then I put in an NG tube and do the 300, and then along with that aspirin.
Yes, and one point here I just want to mention, like when we did that MR angiogram, that is a TOF angiogram, that was probably not
Right.
without contrast, with contrast. So that again, it's a flow dependent. If it's a
Yes.
slow flow, you see that probably the vessel is occluded. It seems like that, but it's not that.
Right.
So that is again, it's a drawback of the TOF. I sent you one study, Jayanto, today that the combined TPA, because of these two cases you are presenting. So, of course, that was a non-inferiority trial. So now, are we in a point where, when the patient is, when we are seeing that probably the mechanical will be required, can we avoid giving this thrombolytics and take directly the patient to the interventional table? Because in that way, we have more things to play with. That is one thing.
Yeah, I think direct MT is now coming up as a viable option. And now we have 6 published RCTs. This one you sent me is the Swift Direct, which is a European study, Woods, Fisher and the group. So I think direct MT and your MR Clean direct IV and DEV trial, and those are 4, 5 or 6 trials have been published. Now, there are points in favor and points against, of course. I mean, people who go for mechanical thrombectomy, they have the points that you save time. There is no chance of this stent-related complications if you have to go do it and all this stuff. But again, the other side of the coin is patients who has got, say, a thrombus at the MC. And by this time, when you go in and the thrombus, after your attempt of thrombectomy, it gets dislodged and going into a distal branches where your catheter cannot reach or stent cannot do anything. The TPA on board can take care of the small branches, small clots. So sometimes
Yes.
additionally can help with mechanical thrombectomy. So I think there is no single answer to that.
Absolutely.
There are some cases we'll find where both are equally good.
Right.
There are
So
some cases where it tilts to one side and the other side. So your judgment, I think in the present day, we have now enough data to go for direct mechanical thrombectomy in some cases, if we believe it works, and other cases we can bridge. Gautam.
So number one, as you mentioned, there's 6 trials. 3 of them were non-inferior, and they proved it. But the last 3, which they could not put that they are either non-inferior or superior, right? Now, if you think of the last case, and if we believe that every minute there are 2 million neurons dying, and if you believe that you are there in the cath lab, the patient comes in, patient has a, M1 occlusion, you go in and do that and take the clot out. Even in higher volume centers like us, we don't have that capability. Number one. Number two, many of the patients that we deal with are elderly patients, 70, 80, 90. And sometimes you cannot access the clot. So then you wasted this whole hour of trying to get the access the clot, and nothing has been done, and maybe you can't even reach the clot. So in those situations, thrombolytics, you give it immediately, and it starts, whatever it does. And if you look at all the studies, the SWIFT Prime and everything, at least 10, 11% or 15% of the population had M1 and they got the TPA, and by the time they were doing intervention, they didn't see the clot. So knowing the whole situation, and even if knowing the whole data, even if the best centers, I think the recommendation and the guidelines are that you start with the TPA or the TNK, whoever has what, and then the intervention can be parallel. And there are a lot of times that we do that because we get the TNK immediately, because now we are not using TNK rather than TPA. And in a matter of 10 seconds or 20, a matter of minute, we are giving the TNK in, and then the intervention. And many of my intervention colleagues also say that they think that after doing the TNK, it's easier to get the clot out. So I don't go into direct MT. We do the TNK first, and then go for the thing.
Right. And Shukalan is
Absolutely,
here.
absolutely. We have seen at least 2 cases after TNK, the large vessel occlusion got opened.
Right.
We took it for mechanical, and by this time the clot was not there. So absolutely.
And I think Shukalan will also agree with me that even in the best of the hands like Shukalan, the access issue might crop up. So patients.
No, absolutely. Yes, absolutely. But the one thing is that once you.
What is the anatomy and the access? So if you have a TPA running, then something is working on them, because you might have difficult access, and that will delay the whole process.
Absolutely.
Or might not even be able to get the cloth out.
Yeah,
right?
That's right.
Yeah.
So,
and those cases, I'm sorry.
No, go ahead.
When you do a CT and a CT angio, so I think in stroke treatment, it's each patient should be personalized. Like when you do a CT angio, you get an idea, and you know that do I have those sort of materials to reach there? If you do not, if you think that you will not reach, absolutely, you just say it honestly that I won't be able to do it.
I think
also your presence. I mean, even if you're in the institute and someone comes in, versus you have to come from home.
Yes.
There's a lot of things. So this thing in our direct TPA, direct MT, we tried from 10 o'clock in the morning till 3 o'clock, where everyone is there in the hospital. Still, we had patients with problem with access. So they first tried the FEM, they didn't work. They went to the other one, they didn't work. Then they went to the radial, and we were sitting out there, and then why are we doing this? So I think and it also creates a less stress for my IR people if they don't have to that this is the last line, right? So my RR people say, why are we doing this? I mean, we'll have to have our heart attacks now that you guys are not doing it, and now like I have to definitely do it, otherwise patients will go wrong.
Yeah,
So,
that's what we-
so,
yeah.
so as a result, we have left that. No,
I think if we are sure about a cardioembolic stroke, patients having an AFib on the table, and he got an M1, nice M1 occlusion at the mid-level with a small clot burden, that is, and a nice anatomy, then the interventionist will itch to take it out
Right.
in 2 minutes.
Right.
Those are the
Yeah.
one-off cases. But otherwise,
and Shukollan is absolutely correct. When we put that TPA or TNK, their hands are tied in a way. Right now they are fumbling, like, okay, we can't do dual antiplatelets. Now we can't, should we give an IA TPA along with that? All of those things become question, right? So it puts them at a much more restricted zone,
yes.
than freelancing.
Yes.
Yeah, one point I want to highlight that what you have told, like when they come, Dr. Jayanto, he says that he asked me how much will be the cost. So I tell it's 3 to 3.5 lakhs because the stent, these wear, then other microcatheter and all sorts of things. But we do not have the luxury to, like in your place, as you have told, that you try this one, that one, and then say that it is not
Sorry, it
recanalized.
didn't work.
That yes, absolutely. So that we are not in a position to do that. And the last case, you should, I think, Jayanto, you should tell what is the.
That's a completely different thing. I mean, when we.
But that's a different thing. But the first thing we consider in our scenario is that one.
Yes.
Absolutely. You have to.
Before selling a procedure, you have to be 100% sure that it's worth for the money for them, because now people are in that term.
Because they're giving all their savings for this, and then if you can say, well, it may work or may not work. Well, wait a minute. The common thing is that I will rather give up 1 life than save 10 lives, right? That's the tendency for everyone. It's your near and dear one, but on the other hand, if you don't have anything to feed for the rest of the family because you take everything and put it in here, and the outcome was not good, people are not happy. It's wherever you do.
Much more complicated these days.
And I can tell you, if this was the situation here, we would have half of the nursing homes closed. Because if we go and tell the families, yes, you have to take care of these people instead of the government taking care of the people, right? They would have stopped saying thank you, and they would have dropped those people. 50% of the nursing homes will be gone. So it's the practical thing. It's the reality. So my thing is like, okay, I can try. Okay, can I try the Tiger catheter this time? Oh, that's like another $50,000. Oh, that's fine. We can justify that. But that is not your case. So you are doing a stroke care at the highest level with the best clinical intuition. And I am, and you guys are doing a great job. I mean, excellent. And I've told you directly, and I don't mean to bolster you, but I'm telling you that you are doing the really high class work with so much difficulty, and it is true that I'm not, here I have the access. I have the whole, village to help me out. You don't have that. So it's total different ballgame.
Right.
I have a question for you, Jayanto, though.
Yeah.
So last time I was in some meeting, either at the Stroke Association or the thing. The TNK has a lesser cost, right, than TPA?
Correct.
So why? So any reason that you don't use TNK?
No, we do use TNK. Now the question is, if you go by the current, the not guideline, but the
recommendation,
yes. Rather license,
right,
by the government, the Drug Control General. Till today, they have approved TNK for first 3 hours.
Oh,
Many people use TNK up till 4.5 hours.
yeah,
I
here
have
we all
also
do.
used 4.5 hours off label. But if
Right.
you go by the label, then it's 3 hours for acute stroke in TNK and Alteplase up to 4.5 hours.
Right.
So this patient, Anonna, used Alteplase because it was beyond 3 hours. Right,
Right,
Anonna?
right.
Yes, sir. It came at around 4 hours.
Correct. So that's why
And,
you use Alteplase.
Right. In
So-
now, our scenario, there's no role of TNK actually. The TNK is not indicated. It's not FDA approved, as you know.
That's right.
And so is not TPA. TPA is not approved after 3 hours, right? This is all from guidelines from American Heart Association,
Right.
Stroke Association.
Yes.
The problem we have with TNK is sometimes TNK is definitely much easier to use, as you know.
Yes.
But the problem is that we don't have the data on, pregnant people with stroke and TNK or wake up stroke on TNK. So those are, central retinal artery occlusion and TNK. So though we don't have the data on that. So as a result, in some cases, we have a blue box and we have a red box. The blue box is the TNK and the red box is the TPA. So, and it becomes a little confusing because the doses are different. So, but apparently all the systems here are changing to TNK now.
Right. Thank you. So I
Thank
think we had fantastic discussions and both the cases were very good. Both the presenters did the job very well. And we learned from both the cases. And this is how we learn stroke by stroke, actually. So thank you everyone for your time. Thank you, Gautam, all the way from Los Angeles to join us. Your presence actually helped us to make the discussions more interesting and lively. Shukalnain is always there with us. And thank you, Sandeep and Linux Laboratories for helping us out with this platform and creating the link and helping out to disseminate the informations. So is there any question for us?
How many we have total number of participants today?
Can you
Sir, yeah, that we'll get back to you in a while, sir. And we, as of now, we have only one question, and I have pasted it in chat box, so you can answer it.
how can I reduce the risk of stroke? Well,
That's a loaded question.
yeah.
So
We can go for an hour on that.
Okay. Sheikh Hassanuzzaman. Okay, Dr. Jaman, I think it's a big discussion, but I think you have to do the right thing at the right time to reduce your stroke risk. But firstly, you have to work on the modifiable risk factors. And if I make the answer brief, then hypertension, smoking, diabetes, lipids, obesity, lack of exercise. These are the 6 things I think you have to take care at the beginning. And of course, other risk factors like family history of stroke is there, and your environmental factors there.
Age is a factor,
and
but these are non-modifiable. These are
and
non-modifiable.
of
These are
course,
not.
I mean, alcohol in excess amount, those are also risk factors. But the first 6 points I mentioned are really, really important, especially hypertension and of course smoking. So these are the 2 things on the top of diabetes and lipids. So and exercise is also very important. So if you take care of these 5-6 points, I think your risk of stroke comes down significantly. Thank you very much. If there is no further questions, so I will thank everyone once again, and we'll come back with the next meeting, sometimes by next month. Thank you, Sandeep, once again, and thank you, everyone. Have a nice weekend.
Thank you, sir, for
Thank you,
giving
sir.
us this opportunity on behalf of Linux to be the academic partner. And
Okay,
we
bye.
look forward to encourage different to organize many such conferences.
Thank you very much. Bye, everybody.
Thank you.
Sandeep sir, can we wind up this meeting now?
Yeah.
Thank you, sir.
How many-
Thank you so much for.
Thanks to you for the support. And may I know